Okay, hi guys. So we're going to be talking about non-neoplastic disease of the esophagus. Now this is going to be a little bit long because I'm going to combine two of the questions together. So we're going to be talking about the malformations, the malformation question, achalazias, diverticular, hiatal herniations, as well as esophagitis and Mallory Weiss, and esophageal varices. So both of the questions are going to be combined in this one presentation. Okay, so let's start with the malformation. So this is going to be the content. When we see, looks like a lot, but like it's going to be fine. So first of all, let's talk about the malformations. Now, in the malformations, there are four things that you can talk about. So esophageal atrasias, stenosis strictures, fistulas, and esophageal webbing. Now, the thing is that you can do two, which is the most important ones are the atrasias and the fistulas, because they can coexist and they can exist in many different forms, like you can see in the picture. Okay. So let's talk about the atrasias first. Now, these atrasias, or before we go into that, I also want to mention that the signs, symptoms, and the esophageal diseases mostly is dysphagia. The most common thing the patient would suffer from would be dysphagia because of the upper striated muscles, and the lower smooth muscle dysfunctions are occurring. And also, most important, we can say, symptom would also be heartburn. Okay, so let's start with the congenital ones. These are often discovered shortly after birth due to the regurgitation after feeding, and they should be treated immediately with surgery. Now, in this case, esophageal atrasias are congenital blind ending. So there's a blind ending with no connection to the stomach, and it can exhibit as the polyhydramnios in the uterus inability to swallow the amniotic fluid, and the postnatal features in this kid would be inability to feed. They would be vomiting, choking, as well as we would say that they would have drooling in the case of the atrasias. Now, so it's kind of like an incomplete blockade due to the fibrous thickening of the walls. Okay. So next one, let's talk about esophageal stenosis and strictures. Stenosis is congenitally narrow esophagus. Stricture is not congenital stenosis. Okay, it's not stricture is not congenital. Stenosis is congenital, but both are basically narrowing. Okay, often the result of reflux or some kind of corrosive esophagitis. Okay, so next we can talk about the fistulas. Now, fistulas are again congenital defects. They're resulting in a connection between esophagus and the trachea. Okay. The risk factors in this case can be old moms, can be smoking, can be obesity. Fistulas, again, remember that these can coexist. So, fistulas can be with or without atrasias. And clinically, when we talk about fistulas, it can lead to polyhydramnios, hydramnion, and it is because excess amniotic fluid because they cannot swallow, regurgitation and vomiting as food can't reach the stomach, abdominal distension because air reaches the stomach through the fistula while the newborn breathes, aspiration, obviously the stomach content backflows from the stomach through the fistula and may result to pneumonia and suffocation. Okay, so these are basically some of the features that you need to remember of the disease. Next, we can talk about esophageal webbing or web. This is the drawing that you can see over here. This is the web, basically what we see as esophageal web. It is a congenital, it is basically when the mucosa of the esophagus protrudes into the mucosa is protruding into the lumen like a semilunar membrane and partially obstructing it. It causes dysphagia for poorly chewed food, for example. It is more common in the upper esophagus and it can be seen in Plummer-Vinson syndrome, in which we basically see esophageal web, sideropenic anemia, and we see beefy red tongue. Okay, so it's called the Plummer-Vinson syndrome. There's an Normally when a patient has esophageal webbing, there's an increased risk of squamous cell carcinoma, for example. Okay. Next, we can go on to the diverticula. Now, I know you've already studied this multiple times before as well, but let's just go through it briefly. Normally, first of all, what is a diverticula? A diverticula is an outpouching of the esophagus through the muscular wall. Okay. Now, the most common type in this case, and we've heard it multiple times, the Zenker's diverticula is very, very common. Now, let's do some classification. So we can actually classify them according to the layers that are involved, the mechanism, and the location. So the layers that are involved can be like true, in which all the layers are involved, or it can be a false diverticulum in which only the mucosa and submucosa is involved. If you watched my previous video, you would probably, or you can watch it after this. We talked about colonic diverticula, and a colonic diverticula is actually a pseudo diverticulum and basically a false diverticulum. Okay, it's the same thing. So you would know that what a false diverticulum is. Anyways, then we can talk about the mechanisms. We have pulsion and traction. Pulsion diverticulum is usually a false diverticulum. What it does is it actually increased intraluminal pressure is present, and because of which there's a protrusion. Traction diverticulum is usually a true diverticulum in which all the walls are involved, and it's due to the inflammation of the mediastinum, which leads to fibrosis. And this fibrosis, sorry, leads to the pulling of the diverticulum. Okay. So next we can talk about the location. Now, normally how we divide them is based on the location because that's a much easier way to do it. So first of all, let's talk about Zerker. So we have upper esophagus in which we see the Zenkers, which is basically a pulsion kind of diverticulum. So increased intraluminal pressure. Then we have middle esophagus in which we see, which is basically parabronchial, an example of a traction diverticulum. And then we have a lower esophagus in which we have the epiphrenic, which is basically a pulsion diverticulum. Okay, great. So next, let's move on and talk about it more in detail. So we can talk about the Zenker's diverticulum. This is the most common one, 70% of the time. You can see the picture, what it looks like, because it's a very good illustration. It's very hard to imagine Zenker's diverticulum. Normally, it's an acquired defect, which basically creates a weak point in the pharynx. So it's basically through the pharynx, okay? Because of the pharynx, where we normally have the pharyngeal constrictor muscle, does not overlay in some people, and this may lead to it. A pouch or verticulum of the esophageal mucosa protrudes posteriorly. Please remember that it is located above the upper esophageal sphincter because this allows us to actually differentiate different types, right? Now, so Zenker's diverticulum is basically a false diverticulum, okay? It's a false type and it is outpouching of the pharyngeal mucosa. It is an acquired defect and due to the abnormal pressure, and there's a defective relaxation of the cricopharyngeal muscle, which leads to the stenosis of the upper esophageal sphincter, and this basically leads to it. Next, we can talk about epiphrenic diverticulum. This is above the diaphragm, arises due to the dysfunction of the lower esophageal sphincter, and in this case, the symptoms would be dysphagia, obstruction, halitosis, like bad breath, basically, because there's rotting food in the pouch. And we would see that they would have like aspiration pneumonia, like complications would be aspiration pneumonia. They can have rupturing of the pouch, leading to, we can say, mediastinitis, and they have a squamous cell carcinoma risk as well. Furthermore, if we talk about the epiphrenic diverticulum, diagnosis can be with barium swallow, and treatment is normally surgery for these cases, right? So normally these two would be enough. But in the case that they want more from you, you can mention about you can basically mention about this other kind of diverticulum, which is called a traction diverticulum, which is basically a true diverticulum, and it is near the tracheal bifurcation. Either they can be developmental or it can be due to inflammation. Like there can be an inflamed adjacent lymph node attached esophagus wall and undergo fibrosis, which would tend to contract and pull the esophagus, leading to this kind of a pouch formation. Okay. Um, cool. So next we can talk about the esophageal. So we talked about the webbing. We talked about the esophageal diverticula. So let's move to the hiatal herniation. Now, from the previous videos, you obviously know what a hernia is, right? Protrusion of any abdominal structure. 95% of the time it is a stomach, but we're saying that when we talk about hernia, any abdominal structure can protrude into the thorax through the esophageal hiatus. Remember the hiatus, where it is occurring from the esophageal hiatus, and of the diaphragm, and this causes the loss of the reflux barrier, and fluid can actually enter the esophagus from the stomach. Okay, so now the most important thing you need to remember is that there can be different types of herniations that can occur. So we can have, for example, sliding, we can have paroesophageal, right? Or we can have a mixed in which we have both of the types. Now hiatal herniation can be sliding herniation in which the proximal stomach herniates through the diaphragm, and this can actually cause GERD, it can cause ulcers, it can lead to hematemesis, or we can have rolling hernia in which part of the stomach actually bulges into the thoracic cavity with the gastroesophageal junction of at the same position. Now, if it is congenital, it may cause like lung hypoplasia, obviously, because it's moving into the thorax. So it's very logical that the lungs would will basically be hypoplastic in these particular children. Okay. Now, when we talk about the etiology of hiatal herniation, we would basically talk about increased abdominal pressure due to whatever reason, like pregnancy or due to chronic cough. It can be due to the weakening of the diaphragm in obese people, for example, they can have a weak diaphragm, and this can basically lead to, we can say, these kind of herniations. Now, the symptoms, as I said, that GERD, abdominal pain can be present, and the diagnosis is normally again through the barium swallow or endoscopy. And it is treated with surgery, or we can have lifestyle modifications like giving birth, losing weight. Complication is that we will be talking about GERD later, but GERD can actually lead to reflux esophagitis, which can lead to a Barrett's esophagus, and this can lead to dysplasias and can lead to an adenocarcinoma. This is a very important concept that you need to remember. They love Barrett's esophagus, it's their favorite thing. So please do remember that reflux esophagitis can lead to a Barrett's esophagus. Do remember what is a Barrett's esophagus. It has been mentioned before. Remember the change that is occurring in the mucosa, and definitely you'll be talking about this when you talk about the neoplasias as well. So make sure you really understand what is happening in Barrett's esophagus, right? It's like our body is basically adapting to stress, and so there's a change in the mucosa that is present over there, right? We have columnar, which is going into squamous, right? So there are some changes that are occurring, and you need to remember them. Okay, so let's go to achillesias now. So when you talk about achalasia, so in simple terms, it's basically the lack of relaxation. Okay. So there's an inability of the lower esophageal sphincter to actually relax due to the degeneration of the ganglion cells in the mind direct plexus. Okay. And in this case, the lack of inhibition means it is constantly contracted, and peristalsis is also disturbed in this case. So it is normally a peristalsis in this case. Okay. Um, Furthermore, when we talk about achalasias, they can be either primary, which is basically idiopathic, and it can be like an autoimmune destruction or inhibition of the ganglion cells of the esophageal mesenteric plexus, which leads to an increased tone and inability to relax. Or it can be secondary, in which we can see Chagas disease. Okay, we know it's called by Troponema cruzi, and it destroys the mesenteric plexus. But it can also occur due to cancer, due to amyloidosis, sarcoidosis, diabetic neuropathies, for example, can lead to it. Macroscopically, very important, please remember macroscopy. Macroscopy is dilation of the esophagus. Okay, we can see a dilation of the esophagus, and there's like food that piles up and puts pressure on the walls. So on the X-ray, you'd actually see a bird beak sign. Okay. Clinical features would be dysphagia, putrid breath, frequent hiccups. Complications are very important. There's a high risk of squamous cell carcinoma in the case that we talk about achalasias, okay? And obviously, as I said, that there's dilation of esophagus, or you can say mega esophagus. You can also say mega esophagus, for example, okay? So this is basically achalasia and everything that you need to remember about these achalasias, okay? So you can see it in the pictures as well, that there is um, the lower esophagus is not relaxing. So imagine you're eating food and just piling up in this location, right? And putting pressure on the walls. Great. So next we can move on to esophagitis. So we finished one question, which is I think question number 118. And now we're going on to the second question, which is 119. Okay. In this, we'll talk about esophagitis, and we're going to be talking about esophageal varices. So let's talk about esophagitis. Esophagitis is basically inflammation of the esophageal mucosa. Okay, can be acute, can be chronic, and we can classify it. Either it can be due to an infection, it can be due to reflux, or it can be corrosive. Okay, so by infectious, what do we mean? So it can be caused by CMV, Candida, HSV, but this is more associated with patients who are, for example, immunocompromised, right? And CMV, so what would you see? In the case the patient is infected with CMV, you would see linear ulcers. In the case that they're infected with HSV, you would see punched out ulcers. And in Candida, you probably know this, pseudomembranous, right? We will see plaques. Cool. Next, we can talk about reflux. In reflux, reflux is most common. Okay, patients will come to you complaining about heartburn, thinking it's a heart attack, and you understand where I'm leading with this, right? So inflammation is caused by stomach juices due to gastroesophageal reflux disease, for example, right? Reflux normally occurs due to this. They have a very low tone of the lower esophageal sphincter, which basically leads to it. And the acid, imagine we have like pH 2 within the stomach, right? And this acid is coming into the esophagus. What happens? The acid will erode the mucosa regardless of the mucin and the bicarbonate secretions. The weak lower esophageal tone can be due to pregnancy, can be alcoholism, can be hiatal herniations, can be due to smoking, obesity, and then there's a GERD symptoms. We will always remember that they have heartburn, chest pain, they will have asthma and cough. We would see teeth damage as well because of the acid that is present, right? Then we can say that they will have complications. Now, obviously, what is the complication of GERD? Barrett's esophagus. Okay, so let's move on to corrosive. Corrosive would be like chronic use of NSAIDs or certain antibiotics, or ingestion of causative agents like acids or alkalines, for example. And these can actually cause necrosis. Okay, normally when we talk about alkalis, or we can say lyes, for example, we say lyes. They can basically lead to like liquefactive necrosis. Whereas when we're talking about acids, they're actually leading to coagulative necrosis. Okay. Now, again, what do these lesions look like? They actually present as these punched out ulcers, and mild inflammation can be seen in this case as well. Okay. Now, others can be autoimmune, esophagitis can be due to autoimmune diseases such as Crohn's disease. There can be motility disorders like achalasia, aperistalsis, diverticula, which can again lead to esophagitis as their complications. But what is the complication of esophagitis? It can be, for example, perforations, acute abdomen, for example. Perforation abdomen is different. Please forget that. But it's like perforations or bleedings, or we can say like it can lead to strictures. It can lead to chronic esophagitis, which can lead to a Barrett's esophagus, and which can lead to adenocarcinoma. Okay. Next, let's talk about one more thing that I want to mention is the Mallory-Weiss syndrome. Now, Mallory-Weiss syndrome is basically when the the gastroesophageal junction that we have, it suffers from some lacerations of the mucosa due to some kind of recurrent or severe recurrent vomiting. Okay, like acid, because of the acid and the stretching this occurs. For example, in patients who have bulimia or a lot of alcoholism, right? They suffer they're like alcoholics, so they can have severe vomiting and it can lead to Mallory-Weiss syndrome. Or often they have this painful and bloody vomit, and it normally heals spontaneously. But the complication of Mallory-Weiss syndrome is that it can lead to a Borhave syndrome, in which there is a rupture of the esophageal wall and it's a transmural tear, which can lead to a mediastinitis. Okay, so that is basically uh, Borhave syndrome. Okay, next we can go on to Barrett's esophagus. The reason I mentioned this in my presentation as well is because it is an extremely important topic, and if you get this question, you will be asked about it, right? So in Barrett's esophagus, there's normally it's a metaplasia, okay? I have explained in my previous video what a metaplasia is. So the metaplasia of the cervosquamous epithelium of the lower esophagus into an intestinal epithelium as a result of chronic irritation by stomach acid. Now, right now, I'm using very basic terms like, okay, intestinal epithelium, but they would want you to know the exact kind of epithelium. They want to know columnar, mucus secreting, for example. Like they will want to know what kind of mucosa are you basically talking about, or what kind of epithelium are you basically talking about. Okay. It can basically resolve if the irritation is removed, or it can become dysplastic from metaplasia. It can go to dysplasia and can progressively eventually lead to an adenocarcinoma. And what would we see if we look at look into a Barrett's esophagus? We actually we're actually going to see this kind of red wavy pattern in the esophagus. Obviously, why would we have redness? Again, think about, go back to those chronic and acute inflammation signs of it, right? So and then understand why it would occur, so it'll be easier for you to remember the signs. Okay, so that's done with Barrett's esophagus. I know it's a lot, but um it's all together, so it'll be good for you. um, so now let's talk about esophageal varices, the last part. Now, I'm sure you already know what they are, and you know that they're just dilations of we can say, of the vessels which are present within the esophagus, right? So, it's a dilation of the submucosal esophageal veins. The complications of mostly portal hypertension, we know that. Um, which is mostly due to the portal cable anastomosis shunting. And the portal hypertension can be caused by, for example, liver cirrhosis 50% of the time, schistosomiasis, but Chiari syndrome, for example, and we can say the submucosal veins of the esophagus dilate most commonly in the lower esophagus, and it's painless and it's asymptomatic. But if this vessel ruptures, imagine the amount of bleeding that the patient would have, and it basically leads to death. Okay, it's a deadly, we can say, rupture. It normally ruptures into the lumen, right? So the patient would actually suffer from hematemesis, right? They would vomit blood in this case. Um, so yeah, I think that's gonna be it. But for Mallory-Weiss, you can also mention about, the vascular Mallory-Weiss syndrome plus esophageal varices. In this case, what we would see is that there's a dilated submucosal vein in the lower esophagus, often secondary to some kind of portal hypertension, increased blood flow through the portal cable anastomosis, and there's a congested esophageal veins with atherosclerosis and venous thrombosis. Okay, the complication is rupture, life-threatening hemorrhage, and it leads to common death in cirrhotic patients. But the thing to remember in this case is that these patients don't only suffer from, we said that the most common cause of death in cirrhotic patients is that they have the rupture of the esophageal varices, right? But please remember that these patients also have coagulopathy, so they're not even able to actually form a plug, right, and prevent the bleeding, right? They cannot do coagulation. So imagine they would just keep on bleeding because they already have liver cirrhosis, cannot produce the coagulation factors, and this basically leads to that, like basically leads to their death. Okay, so that's it from me, and yeah, all the best.